Welcome back, everybody, to another episode of the Vitality Code podcast. I am Dr. Jason Farrah here with everybody's favorite well-bearded chiropractic nurse practitioner, physician, and just
The one and
all-around
only.
good human being, Dr. Jeffrey.
Just a good guy.
Just a good guy, Dr. Jeffrey Farrah. I was a little worried, Jeff, that with your beard being our source of strength, our combined source of strength, and it being somewhat shorn, I didn't know how it would handle this past weekend. But I'm flying high today because I survived the weekend of Dr. Dad. It was
I know. I heard, man.
whew.
You were flying solo on the parental units.
I was solo Lobo.
Whew.
Yeah, 3 kids,
Man.
2 8-year-old, 7-year-old, 8-year-old, soon to be 9-year-old, and then the 1-year-old. Oh man, getting all the lunches ready, the clothes ready.
That bedtime was crazy.
It was a little nutty, but I don't know, man.
How
I
many
did
times
pretty
did you
good.
lose it?
Nah, I did pretty good. I even got an old
Yeah.
attaboy from the mother-in-law. She was impressed.
Oh, okay.
Yeah.
Nice.
Then I had to brag
You
about
don't
it.
get those very often.
Yeah, I bragged about it when Morgan got home from Utah. She was in Utah for training.
Oh, jeez.
And
That was not ill-advised. Is this all you do out there? This was easy. I handled it like a champ.
Well, I think any more than what was it? Sunday, Monday, Tuesday. Yeah, one more day, and it would have been. I think the rails would have come off. But
she comes home and there's just ice cream containers everywhere, and everyone's been eating cereal.
A scoop of ice cream dripping down from the ceiling fan. That's like, oh gosh, yeah.
Yeah.
No, dude, I did. The boys are pretty helpful, and they love their sister, so it well worked out. We got a babysitter now, so that kind of helped during the day. And
now the truth comes out.
Yeah.
The full-time nanny was there, and
just during the day while I was at the clinic.
Yeah.
So, what do you think? Want to talk about some prostates?
I think it's time we discuss the prostate health. It's come up a couple times in the clinic this week, so I shot a text out to you, and I thought this would be a good topic for us to kind of broach. It's a topic I think that every person on testosterone, every clinician prescribing testosterone should be aware of, at least have some knowledge base to draw from. And so I think it's a good idea that we go down that road.
Let's do it. What do you got any questions for me, buddy? Oh man, he is prepared, man. Look at that.
I came prepared.
Damn.
Yes, I was getting questioned by some patients, and I was getting questioned by some spouses, and I actually also listened to the Drive podcast with Peter Attia, and I think his name was Schaefer, Dr. Schaefer.
Ted Schaefer, MD, PhD.
It was a good. I liked it. I don't know. It's 3 hours of talking about prostate, so I don't know if the general populace. I'd be interested to see his numbers of how much that one was listened to, but I liked it. I enjoyed it. I listened to all of it.
Producer Nick, I'm going to tell you something. If you look at that on YouTube, you can see, Jeff, that it had 600,000 views as of this morning. I think, and I was you mentioned it. I was looking into it.
Oh, you checked it out, yeah.
And then above it, it was some kind of nonsense about fails or some kind of silly thing, and it was like 6.2 million. I was like, okay. Yeah, 3 hours, 45 minutes on prostates. I get it. But hey, man, he's closing in. He's over.
And I wonder, but how many of those, I don't know anything about YouTube and that sort of metrics. I'm not a big social media guy, but like if I click on it and listen to it for 10 seconds, is that a view, or do I have to make it to 2 hours and 45 minutes for it to count as a view? But nonetheless, I thought it was a really good one. I enjoy the topic, but it's a lot, and it's heavy, and it's deep. I would think for general populace, but nonetheless, that's cool to see. So yeah, I think there was I think part of what I like to do is boil that down. I don't know how applicable the 3 hours and 45 minutes for the general populace was, and all that kind of stuff. So, I just wanted to start just kind of some of the questions that I got, and so let's talk prostate. Before we get that, I wanted to just say, like, what is the prostate? Can you help us just quickly lay some groundwork? Like, what, I don't know that patients, I think they know, but I don't know if they know could describe anatomically what it is and what's purpose and how it could be influenced from TRT. So let's start from the beginning. Like, what is the prostate and its function
Yeah.
anatomically, physiologically?
Yeah, no problem. Yeah, it's not your prostrate. I hear that a lot. What is your prostrate anyway? No, it's a prostate. It's an exocrine gland sitting kind of below the bladder. Every time I'm working down in the open out, well, even in or a laparoscopic case or a robotic case, I see it there. Well, you don't necessarily see it, but you see the outline of where it should be, the bladder and so forth. So it's kind of below the bladder, at the very base of the bladder, and it's anterior or in front of the rectum. The rectum would be behind it if you're thinking about it in 3 dimension from a width kind of perspective. It's a exocrine gland, and it's part of the reproductive system and genitourinary tract. Its job is that it produces prostatic fluid, which makes 50 to 60%, as I remember, of the semen. So it's part and parcel to reproduction, and it develops in utero in response to a spike in fetal androgens. And Ted Schaefer, I'm not a urologist. You're not a urologist, but I want to just say a shout out to Peter T and Ted Schaefer for putting that out there. That was their second podcast on the topic, and that is a cool thing to have at this day and age, especially Dr. Schaefer, who it is his specialty, and giving that information free to the public like that, and an inside look. And the guy speaks at a very high level, but it's very easy to understand too. So, phenomenal physician from that standpoint. I don't know the guy personally, obviously, but his communication style and the information was excellent. And of course, Peter did a good job too. But it looks like those, when you have that spike in fetal androgens, that's going to help differentiate this tissue to be a prostate gland. It's a dimorphic structure, meaning only in men. So women obviously don't have a prostate. I can say obviously, but not everybody. It's something you learn. And then, you have another spike in terms of puberty and androgens, which these prostate epithelial cells and their smooth muscle cells are uniquely sensitive to and help differentiate and create their final function. So they're going to, again, contribute to reproduction insofar as they create about 50 to 60% of the fluid that would be the semen, the reproductive fluid from a man. That's what it is. That's where it's.
So the prostate gland itself is sensitive to, and when you say androgens, testosterone being one of those, DHT.
It's the main androgen is testosterone. There are other androgens in the body, and one of those is DHT, dihydrotestosterone. So there's an enzyme called 5-alpha reductase, which 5-alpha reductase inhibitors target, and those would be like Proscar, Propecia, those things, and they exist mainly or in large amounts that are clinically relevant in the prostate and in the scalp, and so can lead to male pattern baldness or contribute.
Yeah, those are okay.
Yeah, to male pattern baldness. But the funny thing about the prostate, well, not funny thing, but the interesting thing about the prostate is that there's two major zones, as to my knowledge, is there's periphery zone and then more of the transition zone, kind of the meat of the prostate. And if you hear Ted Schaefer talk and you read journal articles on this, you see that while androgens are important, DHT I think is like up to 20-25% times more potent. So whatever effect of growth
for the androgen receptor,
for the
right?
androgen receptor, and
it's affinity for the
receptor. And now in those cells, you're talking about cytosolic receptors, so receptors within the cell. It's the goop of the cell, basically, that then go to the nucleus of the cell and induce transcription, decoding of DNA, recoding, creating proteins and creating, obviously downstream effects that are going to create cell growth and differentiation, things like that. But as we talked about, and it's important to remember, not a lot of people know this. And so that was an interesting podcast that we had a few episodes back. There are cell membrane receptors for testosterone and estrogen too, specifically when we think about endothelium and vascular and its vascular effects. But in this case, we're acting at the level of the cytosol and transcripting, making messenger RNA, proteins, etc., differentiating cells. growth.
So let me see if I can break that down just a little bit. So you're saying that when we talked about the vascular system, those androgen receptors were located on the surface or the outside of the cell.
Mhm.
In this case, we're talking about those receptors are inside the cell,
Right, right.
to cause. Okay,
Growth,
just making sure I understood that.
differentiation, transcription of proteins, and other related downstream effects. One of the big things that you
Expression
see,
of genetic
eh,
predispositions.
yes, or epigenetic events that have damaged DNA, and then those get like
Hmm.
single nucleotide polymorphisms, and then those go on to be replicated, unfortunately, and develop things like prostate cancer and unchecked cell growth. But interestingly, the large portion of the prostate, the meaty kind of transition zone, where a great deal of the tumors are not from, a lot of them from the periphery, um, is uniquely sensitive to estrogen. And so, Schaefer talks a lot, and there's a lot of journal articles that talk about this and peer-reviewed, published, you know, journals, that it's the T to E ratio. So as men age, prostate enlarge, but T is going down, testosterone is going down, and the estrogen
Hmm.
typically goes up, and the
Yeah.
prostate's uniquely sensitive to that T to E ratio. So there's been further studies that demonstrate that, because think about it this way: the big question you're going to have, or a lot of people are going to have, is if am I going to get benign prostatic hyperplasia just from being on TRT? Well, it seems to be the best I can see in the literature and interpreting it that the answer is no, actually. In fact,
Right. Yeah, we'll get to that question. Let's
yeah,
leave that for just a second. Yeah, that's one of the ones I want to get
yeah.
to. So, and so I wanted to talk about the prostate, and so we kind of laid a little groundwork there. And we do a lot of testosterone replacement in our clinics. This show kind of heavily talks about some of those concepts, and that's probably one of the more common questions I get. So, before we set up like repercussions of testosterone therapy, what throwing you a softball. What do we as clinicians test? Can you explain a little bit about the blood work that we would use initially to set up that prostate? How do I, outside of a DRE, what is the most common blood work factors, and talk about that? I mean, I'll talk about PSA. So lead us down that road a little bit about PSA and how I would evaluate somebody coming in ahead of time. Like, what is PSA? What are the different? I know there's free PSA. So someone walks in the door. What do I need to do? What am I checking? What do those mean?
Well, again, we have population norms, controls, so to speak. So those will be normal lab values, quote unquote, and then we have what you are longitudinally. So when I see a patient, and again, this goes back to the who's the guy at Harvard? He's the most studied human being on the planet. Anyways, he does a lot with CGM and different things. But the point is that you want to study yourself longitudinally over time and it's comparing yourself to yourself. So I like to
Hmm.
get a baseline PSA. Well, you say what the heck is PSA? Well, PSA is a prostate specific antigen. It is a protein produced by the prostatic tissue to aid in liquefaction of the semen. If the semen weren't liquid, it couldn't be ejaculated and obviously create, do the things that it needs to do to travel, to transport sperm to help with fertilization, obviously, right? So this PSA, this protein specific antigen, is actually a protein, okay, and it's made by the prostatic tissue, and um, it's extremely high concentration in semen, not very high in the blood, but there is a certain amount of leak from prostatic tissues, as there is from all tissues, and that leak will leak. So these cells will leak PSA, prostate specific antigen, into the blood, and you can tell. And that gives you information about the state of the prostate. Okay, so
Okay.
it should be low, and that would be normal, right? And it can be either bound or unbound. Is that where you're kind of going with your questions? And if it's bound,
Yeah, I think patients kind of talk to me like, "Hey, how's my prostate? Do I have cancer?" I'm like, "Well, it's not a cancer marker. It's not like some marker." And I think it's important for patients as well as physicians. I think as more physicians get into testosterone replacement, and we aren't classically trained as urologists, but I think this is something that they need to understand, like the nuance, I think, of what PSA is. So PSA is a marker of prostatic I don't know how you would term
PSA
that.
is a
Like
protein.
it's a
It's a protein. It's a protein secreted by
protein
the
found in the
prostate.
prostate that's found in the blood at certain levels and can give us information about the prostate.
That's right. And so just like any protein goes through its primary, tertiary, quaternary folding, snipping, processing, PSA is the same. So in its completely mature state, folded, snipped, ready to go, packaged, it can float around the bloodstream freely. Otherwise, it does not float around the blood freely and is bound to things like, I think the primary one's alpha chymotrypsin, tryptin rather. There are other proteins. And so when you measure total PSA, you're looking at all the PSA in the bloodstream, bound and unbound.
Bound, unbound. So similar to testosterone, right? I think a lot of guys understand that. A lot of clinicians understand that. You have total testosterone, you have free testosterone. And a lot of times we say that there is this thought, I don't think I say this, but a lot of times there's this thought that free testosterone can be more important for physiological function, right? In measuring its effects, right? So you have a similar setup maybe with the prostate. You have some that is bound and some that is free. And I don't think it's common for a lot of physicians to always check free, but that is a part of the equation, right?
Right, absolutely. I think the old way was total PSA. I know this was my understanding back in med school, and you had, if if your PSA was less than 1, then you had less than 1 in a million chance of harboring a lethal prostate cancer. So we knew that was good. So, and then you look at things.
So let's stop there. So for patients and clinicians, I think clinicians should understand this, but for patients, lower is better.
Yeah, lower,
just at the most basic.
Lower is better so long as there's not other associated symptoms. Not as though you couldn't have a low PSA and low-ish, but on average, yes, absolutely.
Okay. And so when we see rises in PSA, that gives us pause, and that gives us the sort of a basic understanding is when the PSA rises, we're getting more of that prostatic specific antigen in the blood, and that would be cause for potential further investigation depending on clinical signs and symptoms.
Right, because more
like
PSA in the blood means more prostatic tissue, because there's more prostatic tissue to create the PSA, to then leak it out. But here's the rub, right? And this is when it's been denigrated to some degree. But I agree with Peter, and I guess Ted implicitly said, or implicitly said, that maybe PSA is bad because you don't know how to use it, and I understand that. But I think in general, it doesn't mean you have prostate cancer. Was what you said. It just means there's more prostate tissue secreting more PSA. Hence, it's higher in the bloodstream. Okay. So,
or potentially there's some inflammatory process going on that is causing more leak.
Exactly.
Well,
so there could be more tissue or more leak, or more leaked PSA because there's more tissue leaking it. That's right. Or both. So it's hard. And so that's where you get into the free PSA, the unbound and the mature tends to help you determine if the total PSA is how worrisome is it. So the more free PSA you have, the more likely it is to be benign.
Correct. And correct me if I'm wrong. I'm going to go out on a little scientific limb here, but as I understand it, that cancerous tissue is less likely to be efficient in creating fully folded, snipped, complete prostatic antigen proteins, and therefore leak them into the blood, i.e. allow them to be free. The cancer cells that are characterized by maybe quick growth or overgrowth or inadequate doesn't do a good job at completing the prostatic antigen protein formation, and therefore it can't leak as much free PSA.
It just wants to grow, and it's
be
exactly right.
Right.
Think of it like an immature. The cell grows to be a wild, destructive teenager, and then the next cell grows to be. No one's maturing to adulthood to be a refined human being.
No one's getting to adulthood.
To be a refined, contributing human being. But I mean, so that's what's happening. Is and so
this is why we check PSA, and this is why patients should have an understanding of their PSAs. This is why it's important for clinicians to make sure they're including this in their initials, in their follow-ups, in their checks, is because it can give us some information and granted, the better knowledge you have of PSA, the better able you are to use that information.
Yeah, I think so. I mean, I think if ideally you have, you think about the PSA as a screening test. So any screening test has to be widely available, has to be cheap, and then has to be easy to interact upon. I think that's what the last part is, the execution and what to do next. I think it's a little bit misunderstood. And then there's, I don't know of another screening tool that's as cheap and as widely available that you could possibly use. Maybe imaging studies, but those aren't cheap and they aren't widely available, right? So I don't like if we were.
It's interesting you bring that up, Doc. When I was doing my preceptor work with nurse practitioner, I got in trouble for running too many PSAs because the insurance company did not like us to run that lab test because it was considered expensive for a lab test.
Wow, really?
I distinctly remember that. I was allowed to check it one time a year, which I can't say I'm abreast of the knowledge of the data enough to know that more is needed. But whenever I would go to check it, I was working for somebody, so they weren't a testosterone clinic. But when I had my patients who were on testosterone, I would always include PSA, even if it was a second lab of the year, regardless of what they were being seen for. And I was discouraged from doing that because the managed healthcare system that is predominant in Tallahassee didn't like it.
But and these people you were doing it through, they were paying for them through insurance, basically. They weren't cash pay.
Correct. Yeah, that was not at my clinic, but I thought that's interesting. But it is, I think, comparatively, it's still an inexpensive test compared to imaging or MRIs or whatever other method you would choose to evaluate prostate health.
It's real cheap to get a DRE. Well, I mean, maybe not to get one, but
well, no,
you got to go see a doctor. I mean, maybe
you got to see the doctor and you got to pay his visit.
I mean,
there's no specialized equipment.
There's no specialized equipment.
The doctor.
Well, yeah, I guess the doctor. That's one nice.
So let's talk about what's a normal PSA for a gentleman in his 40s. Like, is this something that we're checking? We're not checking much in 20-year-olds, but let's just go to the typical average 40-year-old testosterone patient. Like, if he comes in and his testosterone or his PSA is X, he's good, he's normal. What does that look like?
So normal is always tricky to me, but you might even say average, but then that doesn't really show you. So I would, because it would take all the PSAs, divide them by all the people getting PSA for anyway.
Right.
You have a funky distribution, but the median kind of sort of right in the middle would be 0.5 when you're 40, and when you're 50, the median is 1. So I think if your guy comes in and they're anywhere around those medians within the standard deviation error, then I would consider that quote unquote normal, or I guess I would consider it very unlikely, less than 1 in a million, to harbor a lethal prostate cancer. And
right.
And I wouldn't see
so again, that low number is better.
Yes.
And do you check free PSAs on, say I came in and I have a 0.5, which I think I looked at my PSA and it actually, we can look it up, but mine, I went back and after listening to that episode, and I looked at my numbers and mine's around 0.5, 0.6, traditionally in all my labs. What would you say to me about the need, the efficacy, the reason? What should I check my free PSA? Do you check free PSA?
I don't think the lab won't check it if it's under 1. They can't, because I think most labs, because again, the chance is so minuscule that you'll have so I have not seen a lab that will do it under 1. And then,
right. So,
and then, if it's, I believe, generally speaking, a cutoff that exists nationally that may or may not be adhered to, but that exists, is to check it if it's like 2.5 or over. I think Ted Schaefer mentioned specific urologists may work with their specific lab to have their own specific cutoff. And I think that's something that as a specialist myself, comparing it to other physicians that aren't, I could see where the principle exists that would be useful for somebody who could make that differentiation. So I think in their lab, he talked about under 2 or under 1.5 or something.
2, I think it was 2 if I remember correctly.
But I think the general consensus is 2.5. And then,
often I think about, sorry to interrupt you there. I often think sometimes we defer to specialists, and we should when we're out of our information paradigm, but we should also strive, if this is something that's commonly dealt with in our setting, even though we're not urologists, we should strive to have more knowledge about this even if we aren't the specialists in this area.
500%, 1,000%. And so I'm glad you said that, because the corollary concept to tag along to that is, again, in my life as a specialist working with, the patient does better, the better the generalist can understand the issues confronting the specialist and be conversant in them on behalf of the patient. In some of the workups, and we talked about this in one of our podcasts, but getting with your local area physicians, understanding them, how they work, what they, and creating these relationships goes a long way to create efficient healthcare pathways for patients. Absolutely. The problem that we sometimes do is, or that we run into, is as generalists, and I'm kind of wearing both hats now in this new role, is that you almost outsource the responsibility and the medical legal responsibility to the specialist, and then it's like you outsource all knowledge to it too, and it's almost like almost like you feel like you don't need to have that knowledge, or you're just like, so I think that's a losing proposition for a patient, because the generalist may have a relationship with the patient that the specialist doesn't. They can kind of guide them a little bit, kind of tell them a little bit from their perspective, and deeper knowledge, deeper understanding, and it may change your way of testing and referral patterns and things. So yeah, I think it's absolutely true.
I think 100%. I draw on my current methods from my experience as a chiropractor when I would refer out for a surgical consult with a neurosurgeon or an ortho. Is my policy was, even though I wasn't able to determine whether or not sometimes this patient is truly surgical or not based on their surgical algorithms, I became good enough and I strove to become better understanding of the situation where what is needed for that appointment. So I wouldn't just refer using a herniated disc was my classic example, is I wouldn't just refer out for a herniated disc surgical consult. I would have the MRI done ahead of time because I knew that the surgeon needed that information, right? So I'd have them prepped for that. I would explain to them what are some of the likely outcomes and the surgeon would be looking at. Here's what that process would look like. Here's how you need to approach the appointment. Here's the questions you need to ask. So I would try to grease the wheels so that it wasn't like just a referral. No information was given to the surgeon. There's just a referral for low back pain with radiating down the leg. No MRI was done. Then that was going to require the neurosurgeon or the MRI. I learned, this was interesting, that I learned that the surgical groups here in town preferred different MRI centers over others due to the quality of their imaging. So I knew if I was referring you, Jason, to the neurosurgeon, I wouldn't use this MRI center. I would use this MRI center because
Exactly.
I had a patient had to get the MRI redone. So those sort of things, and I kind of take that approach to my testosterone patients, and I want to be as well versed, even if I'm still going to make that referral. I still want that expert opinion, but I want to know as much as I can so I can have as much of the legwork done, understanding the patient. Here's the process that can happen. Here's it help you differentiate. Here's the things they're going to be looking at, and here's what to expect.
Right, and whereas you could just become a lot more sophisticated in your work with the patient. Let's say you had a guy coming with a PSA of 4, and he was like, it was 3 point, or it was, trying to think of a scenario, but I mean, a high elevated prostate, right? And then you got to follow up free PSA, and the guy didn't really want to do anything. Couldn't it just be from BPH? Yeah, but your free PSA is very low, Whereas if you didn't have that information, so I encourage you to really do this, because we know that the lower the free PSA is, the higher the chance of the cancer. You might have some information about his density ratios, the volume, so the PSA value to the prostate volume, right? So if we're saying a normal prostate is 20 to 25 grams, and then as you age, I wrote down some numbers. I think 40, you might think about 25 to 30 grams, 50, 35 to 40. I mean, of course, there's different age, different sizes that can be here. Greater than 50 by the age of 75 and different things. So if you have a PSA of 2 and you have if you have a 30 gram prostate, that's why it's indeterminate. Yes, it's elevated above the mean, but if you have that ratio is 0.1. And as I understand it, if it's greater than 0.1, this case would be less than 0.1 because a 30 gram prostate to PSA. If it's less than 0.1, unlikely to be a lethal cancer. Greater than 0.1 more likely. And then, of course, in older men, greater than 0.15, I think was a number that I heard from Ted Schaefer was very concerning. Younger men, that number's lower, like greater than 0.1. So, having some understanding, oh gosh, putting this together, I don't think it's our duty or our job or our role to make those more specific calls, obviously, but I think better understanding is always better for the patient, no matter if you're the generalist or not.
So let's just cut right to the nuts and bolts. 2 questions: does testosterone replacement cause benign prostatic growth, and does testosterone replacement cause cancer?
So no, that's basically what I would say. That there's no evidence to my understanding or in my deep dive into the literature that, and I agree, this is agreed upon by urologists as well, that testosterone doesn't cause prostate cancer, insofar as epithelial cells and smooth muscle cells in the prostate are responsive to androgens, and then you can have single nucleotide polymorphisms, or maybe a germline mutation, which is very rare in prostate cancer, but not zero, or some other tumor suppressor gene that's gone awry, etc. Then you can have cancer that's responsive to in vivo, or androgens inside the body, or exogenous or endogenous androgens. But even that is really nuanced. If you listen to Ted Schaefer and some of these other guys talk about the genotype to phenotype expression and how these tumors behave, and trying to drill down on precision medicine. Whereas, so here's the thing. So no, it doesn't cause it. Could it make it grow if it was androgen sensitive? Yes, but it's been the observation that the more lethal cancers are from the basilar cells, not the luminal, and they tend to be less dependent on and responsive to testosterone, and the more benign but still cancers, which have a very hard time living outside the prostate. So locally aggressive but terrible at metastasis, those tend to be more responsive to estrogen. They'll cause you problems in your lower urinary tract or otherwise, or surrounding structures, but they won't kill you and they won't spread. Those, they're responsive to testosterone. Can't seem to live without it in places that are. So it's a funny thing. They'll grow more in the prostate, but once they get out of the prostate capsule, where you might not have DHT, you might not have these other hormone receptors and things, they don't grow well in the bone marrow. They don't grow well in other distant sites. The other ones.
So the environment of the prostate is more, from the cancer's perspective, more beneficial for them for the growth. But once they come out into
now
those are more responsive to testosterone,
right? So, but they're not as metastatically powerful. The ones that are metastatically powerful are less responsive, and they're less locally destructive. So, it's a funny conundrum. So, it's not straightforward at all that prostate cancer, or excuse me, that testosterone induces prostate cancer, causes it. Well, I mean, it's straightforward that it doesn't, but then even then the effects on prostate cancer are not straightforward. Think about it this way. One of the observations was that young men have massive high rates of testosterone, and they're not getting prostate cancer. They're not getting BPH. On the case of BPH, you think, okay, well, it's more testosterone to estrogen ratio. A young man will have a very favorable testosterone to estrogen ratio. An older man, because of accrual of increased fat and subcutaneous fat and visceral fat, has more aromatase around, more estrogen. They tend to have a higher estrogen to testosterone ratio, and they will have problems with BPH. Okay, so that testosterone gets converted to estrogen and becomes locally active in the transition zone in the meat of the prostate, and creates a lot of problems with benign adenomatous changes. On the case of the cancer, you just have a lifetime. It's just a time code. It's a codependent variable of time, and that is a time to accrue these epigenetic events, oxidation events, mutations, things like that. So it's not the hormone that's causing it. In fact, it's been
lifestyle, right? You're saying,
yeah,
those oxidative events, smoking, stress,
right,
lack
food
of
sources, lack of exercise,
diet.
yes, those are hugely related to prostate cancer. And so it's easy to say that testosterone, get off testosterone because you might get prostate cancer, or if you have prostate cancer, you can't have testosterone. But that leads to that's unfortunate because it's not true. It's not nearly the complete story, and lends itself to people having to suffer needlessly uh, in those settings. So the answer is no, no.
So yeah, one thing I wanted to talk to you about, and I don't know if you noticed this in your clinic, but I've noticed it. It seems as if men maybe are not as up to speed or not as knowledgeable on their family history when it comes to prostatic health. Don't necessarily know about their fathers or their uncles and prostate diagnoses and cancer or BPH or urinary symptoms. And is that something that you also find to be true?
Yes. And so I was just sitting here thinking that it seems like men in general are bad at that, no matter the disease state. Although, and anything that you say, anything I can say is going to be biased based on our experience. So but with that in mind, the more I think about it, I think people always tend to be pretty dialed in, or there's a higher chance of being dialed into cardiac events and strokes. And I wonder if that's just because those two, they've done a better job marketing, or in society, people understand that. I mean, but again, remember, second leading cancer, second leading cause of death, cancer related in men, prostate. So
Yeah.
if it is
Number one is lung, number two is prostate, number three
colon,
is colorectal.
yeah. So I don't know if it's because they fear getting their prostate examined. I don't know if they fear just
Yeah.
anything to do with genitourinary health. Because, well, think about it. It makes sense too, because it's not like women like going and getting pap smears or dealing with vaginal related things, but they've been, fortunately or unfortunately, they've been
Conditioned or trained or
conditioned or trained, right?
expected
Yeah,
or
because you got to deal with a period age anywhere from 9 to 13, right? And then through life, and then you have to get these pap smears and different things, mammogram. So men don't have that lifelong conditioning. You're right, conditioning.
and then I think the other thing that I I think women are more attuned to, and this is, I hate to say the word marketing, but there is the marketing aspect to it, if you want to call it that, of like the breast cancer health. And when I ask women what their breast cancer history is, they seem to they know, right? It's not as common for them to be unfamiliar with their moms, their mom, their aunts, their sisters, siblings, things like that. But men don't seem to have that same relationship to their prostatic health. But women have been taught to know that history, and men have maybe not necessarily been expected or taught to
Agreed,
understand that health history.
agreed. And women generally are more. We're different, right? So it's a fact if you look at psychologic studies and sociologic studies, anthropomorphic studies, and yada yada. Women in general, and there's nothing wrong with this, but women in general tend to care more about relationships where men care more about things. And I'm going to communicate more readily with you man to man about a thing or things. We're brothers, so it's a little bit different, but in general, then I'm going to confide in you about my prostate health. Whereas women,
It's not talked about in the locker room.
I don't think so.
That's your prostate, boy.
Yeah, buddy.
Well, that's true. Without the risk of divulging people's family history without them wanting to, but my wife has a strong, significant family history of breast cancer in her side, and that is commonly talked about from her and her family and with her friends. And we were just having this discussion prior to talking here that I had no idea of Dad's prostatic health challenges. And here my wife is talking to her extended family, her friends, talking about what options they have. If you were BRCA positive, if you weren't, would you do a double mastectomy? These are not common. These are conversations she's had more than once. And I didn't even know that my father had a significant prostatic health history.
Right.
I was like, geez, you never even mentioned it to me. I didn't even ask and never even thought to ask. And so
what's the what's the famous organization that has a race dedicated to breast cancer health?
the Susan G. Komen.
Oh, you knew that, didn't you? What's this common symbol of breast cancer?
The pink ribbon.
What's the common color of breast cancer? Pink, right? Look at that.
Pink.
What
They have a month.
was that?
There's a month too.
Oh,
October, right?
is it October? Yeah,
I believe it is.
but look at that. You knew all those. Okay, now is there? I don't even know if there is one for prostate. I don't know any. I mean,
hell if I know.
Right. See, so what's gone on there? Right. What's happened?
It's marketing. I just generally you call it marketing.
I would say so. I hate to say that, but it seems like
it has a negative connotation, but I think it could be positive marketing.
Oh, it's absolutely because we don't want women. I don't want women dying from breast cancer. I don't want my mom. I don't want my wife suffering from it. You don't want your mom. You don't want your wife. You don't want your daughters. Right. So right. Marketing is good because it raises awareness, but why hasn't it happened in this arena?
Now that you say that, we've even talked because my wife is BRCA positive, and so we've talked.
Wow, really?
At what point? Yeah, at what point we'll have the girls tested, and so we've had these conversations. And I don't know anything about my family history of prostatic health, but I do know Dad had colon cancer, so I went and got a colonoscopy really early, and so. That has made learning about this prostate to a different level for this podcast, and having talked to you about Dad's health has made me, and I'm wondering what you think about this, has made me, I've already started the process. I want to go get a prostate MRI. And so I've started to look at things through a different lens, being a cash-based clinic and a private clinic that's not beholden to managed care guidelines. I don't have to make decisions based on the insurance company's risk mitigation steps, meaning I don't need a high PSA before I can order a test. I don't need a negative ultrasound or a positive ultrasound before I can order the MRI. I don't need those things. I can just be like, for me, and this is me dealing with me personally as my patient, but as the one making the decision as well, it's like, I'm skipping all that. I'm going to go get an MRI. For me, the cost-benefit ratio is there. I just wanted to bounce that idea off of you for patients, and maybe not something you'd order for everybody, but
no, I think that's a fantastic idea, and it's sad to say that ownership in our free American society and English common law, similar societies, ownership's not based on need. Nobody needs a Lamborghini. There's nobody stop. As long if you have the money, you can buy a Lamborghini, right? But if you want to get a prostate MRI, they're gonna be like, "Oh, you don't need one." Well, why can't I go buy a Lamborghini?
Interesting,
right?
Concept.
You only live once. You only live once. If I have the desire and need to get one, okay, why can I not? So I think going outside that managed care now. These insurance companies are trying to run a profitable business. Okay, I get it. That's fine. But actuarial science converging on profit analysis and what you really quote unquote need based on your insurance plan. Okay, different story. But like you're saying, this is the benefit of cash-based practice, rather, having physicians and practitioners that are involved in that, working with patients who can make decisions other than what they are directed to do based on managed care, which is not satisfactory to them. It's not in this day and age with the dissemination of information, and nor should it be. If you live once, and if you have a high family or a heightened family history, if you want, why should you not go get one if you don't want one? Now, if it's clogging up the healthcare system and creating, there's so many spots that are opening that the radiology centers can't handle. The people that okay, different story, but that's not what's going to happen, and that's not what is.
Sound like Fauci, man. Don't pull that shit.
No, I'm just saying. You could see
don't wear masks because I can see that, but I think what you would see is a demand, right? Just like we talked about Susan G. Komen, you now see the insurance regulations have changed. You now see everybody does mammograms. They're easy. They're cheap. You would see the industry respond. You would see the free market respond.
Exactly.
And clinicians. I had to call 3 MRI centers to find somebody that would even do a prostate MRI.
Now you have to,
due to technological concerns, due to the imaging software needed to do that, it had to be a specific place.
Now hold on. The other thing that you can't forget, and Fauci or no Fauci, and your little high mighty horse there is, well, I mean, seriously, you got to think about all. So when you go to get one of these studies, remember it has to be read by somebody, right?
Mm-hmm.
Okay, so that person has to be reimbursed for their time, and every time they read a study, they accrue medical legal risk for which they're compensated for partly, So this is a big deal. And nothing this became very clear to me in the world of trauma, where you're getting people sent in from these little podunk places into a tertiary care center. And I've worked in I've worked in 3 level 1 trauma centers now, actually. Training, and then I've had 2 post-training jobs in level 1 trauma centers. So they will oftentimes comes with partial imaging. Well, now that partial imaging you want to put into our system, and you want is to say, oh, well, you don't need it to repeat it. You can use ours. But then a lot of times they wouldn't come with reads and different things like this. So there was a desire for radiologists to read those studies. The radiologist would contend that, okay, you want me to take all the medical legal risk if I miss something, right? Or something, or otherwise, and I'm not getting any of the reimbursement because you can't reimburse twice on the same study, which makes sense. And so I was like, oh yeah, that's not fair, because I thought about myself as a physician. Are you, it's so
Yeah, I guess I wasn't saying it from that they weren't willing to do it, but the market hadn't been set up for it, because the market is responding to other needs, and it's not something that I think is so outside the bounds of normal that why is it not set up, is, I guess, my bigger question. Not that they should do it with an inferior technology, not that they should do it with inferior software, but it just, if I wanted drawing from my chiropractic, if I wanted a spinal MRI, any MRI center here in town will do it. There's a ton of them. They pop up, they're little pop-up clinics. Right. And if you wanted a mammogram, though that industry has been set and it's gotten in motion, it probably took a little while. But I think it's just not on everybody's standard operating procedure, when maybe, it's not necessarily outside the bounds of normal.
I think what we need to do as a society and as a healthcare in general, and this is going to have a lot of opposition because there's stakeholders that this is important to, but we've got to, the technology, it seems to me, if Elon Musk is sending people to Mars and or nearly to that, and we're sending people into space, we're doing all these other things, and electric vehicles and alternative fuels and blah, blah, why, we, like you said, these things, the price of these things and this technology just go cheaper, Moore's law or whatever it is. I mean, and then we got AI could analyze it based on databases of images, and you could at least get some kind of reading, and we could say as a standard that gives us a first step, and if there is anything based on that you can send to another physician for a reading, at least have an intermediate. The market should respond, and we should make these screening tests cheaper and cheaper. We should do them.
I think the market will respond.
I think it will too over time. It's not nearly fast enough because people are dying. But
and you have, we can go down these roads. You have these ridiculous managed care people called insurance companies that I have little positive to say about.
Right. But hey, let's give kudos. Let's give ourselves a tiny pat on the back. But let's give Peter Attia and Ted Schaefer's of the world bigger pat on the back. Look at the dissemination of information. I mean, when was it in our lifetime that you could just go on a podcast and get massively high quality information like that podcast? And my gosh, what a treasure that is. I mean, what a gem that's out there in the public sphere. And there's a lot of it out there. And that's fantastic. So now we got to be commensurate on the other side of things to get these, like the prostate MRIs. Why should you? I mean, it's insane that you would have to get 3 different.
And then also, here's the thing I've done in my practice is I generally like to go through the process myself first so that I can speak firsthand to the patient. Here's what it's like. I did this with the cardiac because our father had a cardiac history as well. So I went and got a CT scan. I went and got a Holter monitor. I went and got an echo. So now I can speak to the patient. Here's the place you go to. Here's the cost. Here's the benefits, the rewards from the teaching. But here's the logistics things that I have seen. So as a physician, this is something that I commonly do. And so part of me wants to go get this MRI maybe prior to me even ordering some, so I can say, yep, call this MRI center. Here's the cost because I had to pay cash for it. Let's talk about all those options before we go do it. And so I have that advantage too because I run a subscription-based clinic, so the numbers are small and I have more time and I have time to do that sort of thing. It's not always available to everybody else.
Yeah. I don't know if I'll ever order a prostate MRI. I will
I don't
suggest
know.
because
Like,
then what are you going to do with the results? Like I can't
I always tell patients that. Yep.
I can't do anything myself. A urologist could, but I can't. So
So tell me what, in chiropractic, an MRI rarely changed my approach to low back pain,
oh really?
but I would commonly order MRIs, and I did it for a couple fold. I wanted to rule things in and out for the patient. I felt comfortable enough, and I wanted to have that done, but prior to them going for a surgical consult, so to speak. And so I'm thinking about it through that lens. Is I would maybe consider ordering the MRI for patients as a means. Maybe a urology visit's in the works. It takes weeks to get visits to specialists in my town, of a non urgent nature. And so maybe that's something that you go to the urologist with. Maybe we can make that decision whether or not you see the urologist. I don't know. I'm sort of weighing the pros and cons, the med legal risks of those. But yeah, I just
I think I would
concepts
do
that I
it.
think about.
Yeah, those are good concepts to think about, and you bring up salient points that are incredibly valuable. The answer is not always clear to me, and in this case, is the same. Okay, so I think what I would do. I had no knowledge of a pelvic MRI. I'm sorry, of a prostate MRI before this. I thought most of it was done on transrectal ultrasound. So
Hmm.
I think I would look at my community and I would try to partner with a urologist. And I know a couple that are actually good friends of mine and very good guys. One's more of a specialist urologist in terms of cancer surgeon, and one more a general. They're both surgeon because of urology. But and I think I would go into them and run it and just create a foundational partnership with them and
Hmm.
try to run these things. Do you guys do a lot of transrectal ultrasounds? How good is your operators?
Right.
What are you feel like good the sensitivity
Yeah, you
specificity?
keep sending MRIs to these docs. They're
Yeah,
like, "Why aren't you doing an ultrasound, buddy?"
right. And now, but the
Yeah.
MRI sounds like it's the way to go. But da da da. And then I kind of go from there. And hey, it's going to take it's busy. People are dismayed at how long it takes to get into you. What do you think about just run these scenarios by them? But
Hmm.
I think being
Which
educated,
is much harder. Sounds really great, and that sounds really good from a patient's perspective. It sounds good to me, but it's much, much harder because I've tried that on different fronts, and I get
it is.
roadblock after roadblock after roadblock.
You're right. It is. But hey, but listen to this. Okay, so I had a guy come in and he had obstructive uropathy from BPH. Okay. He then came in desirous of improved sexual functioning and had a laundry list including of poor sexual functioning and libido issues. Status post being on finasteride for 2 years. He basically had post finasteride syndrome. Okay.
Hmm. Yeah,
Now,
something we didn't talk about, but
right. uh, So so because we were it's interesting to note that because we were dedicated to this, if we had been in my clinic, right, and we had encountered this issue, then I would say, okay, now that I've learned about finasteride, all the detracting information or features about it and different things, and I could share them in a cogent way with a good understanding, it would at least give that person the ability to go to the urologist in a very educated fashion, much more than them trying to interpret Google on their own, right? Google stuff. And then I think my feeling is, and my thought is that that would help them facilitate a much more productive conversation with the downstream specialist.
hmm.
So maybe you don't have to order those tests, but if you're understanding of them and the value or the current where they sit in the landscape of the current literature, and then you can transmit that information to a patient of yours who in your subscription based concierge medicine model or have a very close relationship who trust you and you're treating. That's a powerful tool for that patient because they don't have anybody else to help them navigate through that maze, and they're just kind of beholden to whatever they run into and whatever they get at the time, rather than having options in their back pocket that they can understand and are backed up by a scientist slash physician slash practitioner. And I think that's a
Yeah, a
valuable
lot
tool.
of yeah. I find that a lot of what we do in our clinic sometimes is health navigation. I'm a big fan of having an advocate. I tried to at least have a
But don't say
level of
just.
relation.
Don't say just because
Yeah, true.
honestly, because I think a lot of people look at it like that, but actually that's huge, man. And
Hmm.
and it can be done poorly. I think and the reason I say this is because you do a lot of things. And again, I'm your brother, so I'm biased, but you do a lot of things that are extraordinary to me, and set you apart from a general practitioner in your same realm or whatever peer, because you take that extra mile, you do that extra step, and you are always seeking to understand at a deeper, higher level. But when we all say, I'm just this or I'm just that, it's almost like we're making it okay to benchmark at a lower benchmark. And that's not okay. And when the reality is, no, it's okay for you to understand these things on a deeper level, and thereby be able to help your patient. And that's what you do and are example of. And so I think that's a good thing, and thing that we need to promote. So
Yeah, I agree. So let me ask you to bring it back full circle. If you were in my position and training, say, a med spa clinic, so you're not you're running a testosterone clinic. They're popping up, they're mail order, they're spa clinics, and the urology says you shouldn't have testosterone because of your prostate issue. What do you recommend that clinician does?
oh gosh.
But I'm the patient, and I want to continue testosterone. But now you're in that position of like, these are the kind of the people that I'm teaching sometimes. What do you tell that doctor?
I would tell the doctor that doctor needs to be up to date on the most current literature and rationale. I would say, now you use the word, sorry to call you out like this, but you use the word prostate issue. So I guess the first thing I would say is, what is the prostate issue? Because that to me would inform if the issue was androgen sensitive metastatic prostate cancer. I'm gonna say, yeah, I agree. You probably shouldn't use testosterone. But then again, even then, you have to wonder, right? It's a
Yeah, you're
fine
thinking
line.
like you though. You're not thinking like I'll just, what I tell people is you have to know your expertise and you have to know your level of education. So I just think of like these mail order places that are popping up, these med spas that maybe don't have somebody, or who are owned by corporate entities who aren't necessary, who are looking for classically for number driven outcomes as opposed to patient safety, patient satisfaction numbers. I tell them you need to understand your knowledge base, and you don't practice outside of that. And if the urologist says no, I would recommend that you don't.
Oh,
If you're that practitioner.
oh, absolutely. I guess
Yeah.
you're right. Okay, so sure, from that standpoint, yes, yeah. But was there any other answer but that? I mean, I guess,
There shouldn't have been.
yeah. I mean,
But I see that in some of these clinics, is that because they're driven by a sort of a more corporate entity who commonly are businessmen who don't understand that not everybody that walks through the door is a candidate for your product, right? We're not selling t-shirts, we're not selling gym memberships, we're not selling, you know what I mean? But they're like, why didn't you write that guy a script? And so I find this little, like, I'm trying to teach a clinician who's working in that setting, and they're being behind closed doors talked to by their owner, who is a businessman. And so they're being told to do one thing, and I'm like, I would not do that. You are not set up to order MRIs. You don't know the MRI centers in town. You don't know the referral routes.
exactly.
Those are all big things. Like my staff knows who to send an MRI to, knows what urology center to send it to, knows the doctor's names, the fax numbers, the process, what insurance is taken, what insurance is not taken, how long it takes to get a referral. All these things that if you're working in this pop-up testosterone only, sometimes called men's health clinics, but they're just testosterone clinics. I think that the patient should understand what they're getting into, and the clinicians who are running those should also understand their limits of their scope of understanding.
Well, the business plan in any of those models and anything in healthcare in general I would assume would have to take on medical legal risks. Even let's talk about a famous or just, a pretty famous book that came out about 10 years ago, and it's in the common parlance. Have you ever heard of blue ocean strategy?
I've heard it,
Okay,
yeah,
so they
but I
talk about
guess I've read it.
they
Yeah.
say how to create these blue oceans where you create opportunity while minimizing risk. So every business risk minimization, risk mitigation is no matter if it's healthcare, but obviously it's very, to me at least, it's very obvious, and in society, I think it'll be very obviously, oh, I'm going to sue that doctor, I'm going to sue this hospital or whatever. So I would assume that risk mitigation would be in the business plan of these places, but maybe not. I guess
Well, it is from a lawsuit perspective, but I think that's much different than an individual patient and understanding the best management for that patient at that time when it's not always dollar driven.
No, I know, but I was speaking to the point where you said these practitioners were getting driven by the corporate types behind them saying
Gotcha.
more numbers, more numbers. Well, the corporate types shouldn't be saying that in this case because they should say, "Whoa, don't bring that risk into this business model. Don't bring this risk upon
Right.
us."
And that's exactly what I tell them. I say there's so many candidates who have so little, like, take the low hanging fruit, 0 risks, great candidate. Why would you take this 1 or 2 or 3 patients who are high risk? Like, they're not making or breaking your practice if you don't get them as a number, as a client, right? But they will break your practice if you inappropriately manage them as a high risk patient.
Right. So I guess to answer your question, what I would do, and again, it depends on your model, depends on your time, depends on your inclination, depends on your knowledge base. But if the urologist said no, I would want to know what prostatic issue it was, and then I would want to say why did they say no, and then because if the lack of testosterone was creating a massive quality of life issue for the patient, I would want to try to help the patient understand and navigate through that no. And is there any part of that no that may be up for interpretation or in error or not current with current literature, and then have them go back armed with that information to potentially reconsider. But in general, I agree with you. If if the urologist
For that
says
setting only, I guess, is what I was speaking of. Yeah.
no,
For that sort
if
of
they're
like,
saying no, then yeah, don't be a cowboy. I mean, no, but I would
and maybe so for a patient who needs to understand who's managing their healthcare, they have a urologist telling them no, and they have a total men's health type clinic kind of thing. Nobody in specific there, but just does testosterone replacement mail order. And they're saying, well, you're still fine, or not maybe checking their records. Maybe they don't inform the clinic that they went to a urologist, those sort of things. Maybe understanding that sometimes you need to stay in your lane a little bit and understand
But it
what's.
was interesting, right, to hear Ted Schaefer talk about testosterone in that setting. If there was a patient needing testosterone because they were symptomatic from hypogonadism, and his thoughts on the it being on testosterone after having had prostate cancer that was treated. So in the adjuvant setting, and perhaps it was not as much of a concern because if you had a recurrence, it was going to be one of these weaker, maybe more locally an issue, but weaker cancers, right? And not lethal cancers. So perhaps in those situations, they could be on. I'm just simply pointing out that it's more nuanced than what it seems. But if you are in a TRT clinic, in one of these pop-up clinics, and you don't have these support structures around you, and the urologist says no, yeah, don't be a cowboy.
Yeah.
Do it.
Or and maybe take some onus on yourself to learn these kind of topics.
That's where yes, that's the second part of that answer, and just as important. Absolutely, I agree.
So before we wrap up and leave, what do you after looking at this information, knowing our family history, are you going to do anything personally? What's your steps for your personal management? Just wait and watch. Do you check your PSA levels? Do you check your free PSA? Do you where are you at? Take any specific supplements? Anything?
I don't take any specific supplements. There's been conflicting data on saw palmetto, for instance, and so it's kind of unknown to me. How, I think I take the supplement of exercise, and
That's a good one.
trying to avoid a sedentary lifestyle, nutrition, those
lifestyle management. If you're having prostatic urgency frequency, right? We that's a big one. Like
I would tell, yeah. So me personally,
caffeine, water intake, close to bedtime.
Exactly. I would do all those things. Number one. Number two, I would.
Do you do them now?
No, but I'm starting to wonder at age 47, coming up on 48, if I should. I'm starting to feel.
I mean, I pee once a night is probably my average. 4 to 6 times, but I don't manage my water intake or fluid intake close to bedtime at all.
I think I have early BPH. I do. I would just be honest with you. I think and I'm very sensitive to things like sucralose and different things. These are known to be bladder and prostatic irritants. So you can have their caffeine.
I didn't know that.
Yeah. So
caffeine,
alcohol, because they inhibit ADH, and if nocturia, I'm usually a 1 or 2 time a night. So it varies. Some nights I'll be 3, and then I'll go for a week 0 to 1. Like, it's bizarre. So I don't really know what's going on there, but If I went and journaled, that's where a journal would come in handy, because you know how much you drank, how close. Another thing too is I try to stay hydrated, make sure my bladder was getting fully distended, so its compliance was staying good. I'll do that. I'll avoid those things as I get older. If I ever have to go on medication for it, I definitely won't go on Proscar. Absolutely,
I was going to ask you
hell
that.
to the no. I mean, I would use an alpha 1A uroselective alpha inhibitor like Flomax, Rapaflo,
Flomax.
etc., because those are specific to prostate.
That's bladder, or is that prostate?
Prostate smooth muscle and genitourinary bladder smooth muscle. So I would do that. And yeah, I check my PSA regularly. For me, I think you know, especially when you get to the age 40 and above, or family history. And I do not know the urology recommendations, honestly, but I would say,
no, we're just talking from you as a patient.
Like, me as a patient,
what do you do?
Me as a patient and my TRT patients at least yearly. And then what I like to do is anything that might incite a change in the hormonal milieu and thus a change in the PSA in the prostate. So I do it upon dose changes at the point at which I could expect a steady state. So a month after initiating injections, maybe 6 weeks after initiating a pellet dose change, a month after initiating an injection change. Because they're cash based, it does cost me no more cost to the patient to get on the follow-up labs to get a PSA than not get a PSA. So I tend to just generally get it. And the lab gives me an automatic free PSA if it's greater than 2, I believe. And so I check that, and I would do the same on myself. My PSA personally, as yours has been 0.5 to 0.7, and I've not qualified for a free PSA percentage because it's less than 1. So those are the things I intended to do going forward. Now, if it came down to me thinking, and if I felt like BPH was becoming a problem for me, I don't see myself, based on the current literature, stopping testosterone. I do.
Yeah, this was my next question.
I would pay attention very closely to my estrogen, and likewise the ones in my those in my practice, which I think now, especially at TDE ratio, thinking about the meat of the prostate, the transition zone. If for some reason I thought that stopping the testosterone would help, which I don't, but if I did, I think I would say, no, it's too much of there's too many benefits. I think I would just go get a procedure surgically if I needed to.
Yeah. Now, do you think that's influenced? I was going to ask you that specifically too. Like, you are a surgeon. Do you think you look at surgical procedures differently? And would you maybe in the management, if the doc's like, because I don't see this probably offered to patients very right off the bat, but like, let's try some Flomax, let's try some management, let's do the wait and watch. Would you be like, let's just do a surgical procedure?
Am I biased? Yes. I would tell you this is funny. I'm actually generally probably more fearful of surgery than not, because I've seen so many things.
You've seen it all.
So what that translates for me is I would be ultra super careful in my surgeon selection. I would try to find whatever procedure I'm doing somebody that does it a lot in a center that does it a lot. Ideally with low turnover, and I would be very picky if I
Probably seeing all the things, right?
Exactly.
Yeah, elective
surgery.
Yeah, you don't get it if you get stabbed. You don't get a choice. Let's get to the hospital.
Yeah, I don't want to die. I have a shot at living. So, but elective, yeah. And of the procedures currently available, I'm not a urologist, so I'm speaking somewhat out of ignorance.
As a patient, yeah.
As a patient, I don't like the idea of a TURP. I would look at something like STEAM, TUMT, or really what I would look at is holmium laser, this HOLEP surgery. I think that is fantastic in surgeons who are at a high level and do a lot of it, which the folks at Northwestern, there's a female surgeon, I forget her name, that was kind of Ted Schaefer sung her praises in the Drive podcast and said that there was about 10 of her in the country that were at her level with this HOLEP surgery. It's an outpatient procedure, and the results are fantastic in her hands, and I guess in these other 9 other individuals. As best I could, if I could afford it and I had the means to do it, that's where I would want to go. And I would give medicine a chance. It all depends on the severity of the symptoms. But I wouldn't hesitate to go to a surgical procedure. I would just be a lot more picky. And that probably has somewhat to do by being a surgeon, yes.
I think pickiness, I think there's this, and we're going off on topic here, but I see this in patients when they get in front of some physician or doctor that they feel like they don't have a say in who they see. And well, Bob told me I should do this. And like, well, did you talk to his partner or, another clinic? And did you get a second opinion? Well, I thought about that, but I didn't want to hurt his feelings or something.
Oh,
I,
screw
I,
that.
I think as I had the same sentiment as you, having whatever practice I have in health, I'm much more picky in who I will let, make decisions for me or do procedures and things like that of a nature. I'm much more picky. But it's interesting. I don't think either of us would pick the standard protocols as laid out by managed healthcare.
And what would those be?
Wait and watch and mitigate financial risk of the insurance company.
Yeah, exactly.
I'm not jaded at all.
Not at all. No, I agree though. But I mean, I think that's important. I think that's the shift in healthcare that is coming, and hopefully things get more and more affordable so that we can have more and more of those educated decisions being made by people for themselves. Because again, you only live once, man.
Yeah, and affordable is a relative term.
I
Like
know that's true.
we've talked about this. I'm willing to, and my thought process has changed. I'm willing to spend more on my healthcare as I probably because I'm getting older, but as my mind shift has happened, I'm willing to spend more, and the dollar amounts that it costs to get things done are less some for me. I don't look at it like it's not really worth it. I'm like, that's worth it. It's my health. And so I
Absolutely
kind of
worth it. And it's
approach it
I agree.
differently.
I agree with you. You're 100% right on this, and you're right on the money with this because people often will value things, clothes, shoes, cars, whatever possessions, and they'll put their health way down the totem pole in terms of their cost outlay
Hmm.
from their
Hmm.
budgets. That's crazy. And I agree. We talked about, one of the eye-opening things was, again, LeBron James is talking about how much he pays to maintain himself and keep him at his best performance. And while we're not all NBA athletes, we're all human beings in our health.
It's
Absolutely.
relative. It's just a percentage. If you
It's
make $1 and
exactly.
you're going to spend 20%, then it's 20 cents. If you make $1 million, it's
Absolutely.
20%.
And we've got to change our mindset in that regard. We have got to pay more attention to ourselves and treat ourselves right and put more emphasis on our health. We don't have to do anything, but I think that's the better life.
Sure.
Personally.
And it's not the extremes, right? Doing nothing. And there's this internet guy that's trying to push the longevity side and is doing all these silly, millions of dollars and 25 supplements every day. And, and I don't think
the guy
that's
trying
probably
to turn back his clock
yeah,
and
his age. I don't think that's for me. For him, it is the right answer because he's doing it. For me, that's not the right answer either. And
right.
that's what I tell patients. Here's something I tell my patients too is I like to explain my decision-making processes to them prior to me making decisions. Meaning, here's the algorithm I'm coming out of. Here's my mindset. Here's some of the biases I have. Here's how I'm trying to do it and make my decisions so that you understand where my answer to your question is coming from.
Yeah.
I don't think physicians do that at all. And I think at least it's helping me help them understand where my thought process is. And you can say, yeah, like I'm a little more risk averse than you are, Dr. Farrah. I'm going to make a different decision. Or I'm a little less risk averse, or I'm a little more cautious, or I'm a little more
right.
proactive, or I'm a little more wait and watch, or whatever. So,
right. I agree.
All right, brother, it was good. It's good to talk about prostates. I'll go get my MRI.
Are you going to share with us on the show?
Well, yeah, I mean, I guess we have to, right? So let's talk about the nuts and bolts here. So I'm 45. I do have a low PSA, 0.5, 0.7-ish, last time I checked. So what should my grams be? It should be in the 30s, you said?
45. It should be approaching 30 grams. It could be. It's a 20 to 25 gram size of I think I wrote these down. Walnut or something, or maybe apricot at your age is pretty.
I'm an apricot.
It's pretty normal. So
if we get a 60 grammer, I'm in trouble. But my symptoms are I pee one time a night. That's pretty common
yeah.
I don't manage my intake of fluid around that. I don't have any genitourinary symptoms that I'm aware of. I don't have any prior history of prostatitis. I don't have any histories of UTIs. So
you're looking at the median PSA. You don't have symptoms. I would expect you to have about a 20 to 25 gram prostate. The other thing is too is remember that's the only weight. That's the only the weight. So the volume can be different than the weight, and that relates to the density. So meaning like you can have 25 grams of muscle is a lot smaller volume than 25 grams of fat, because fat is way less dense than muscle, right? So don't forget there's the height, width, and length of the prostate. So, and that can cause urinary symptoms just based on that. So it'll be interesting to see the dimensions other than just the weight.
Yeah. I think I just want to track it. That's part of why I want to check it now, is when I get a test again at 65. Like, I'm not a hypochondriac, so to speak. I'm not going to do an MRI every year. But I would, if it comes up again, I'll at least have a baseline. Well, when I was 45, it was this. It's growing pretty quickly, or it's not growing very fast at all, or
That'd be interesting.
We'll find out.
What age did you have a beard?
Is there any correlation between beard and prostate?
Was there in the 3rd grade? Did you have a beard? Massive DHT converter?
Oh God!
Yes. Beard at age 8, bald by age 28. I don't know.
I think you're just jealous because you can't grow one. How long has that been going? Like a month?
I'm totally jealous. No, it's only.
Have you shaved?
It's only like a week.
Move that microphone. I can barely see it.
It's only like a week.
Abysmal. That's abysmal.
Yeah, you're in the top. You're in the elite. You're in the bell curve.
I shame you.
Just looking at you makes me feel inadequate. All right, man.
All right, brother.
We'll see you next time.
All right, brother.
Bye.